Good morning. We'll get started again this morning. Welcome to day 2 of this public meeting of the Physician-Focused Payment Model Technical Advisory Committee known as PTAC. My name is Angelo Sinopoli. I'm one of the co-chairs of PTAC along with Lauren Harden. Yesterday, we began our day with opening remarks from CMS Deputy Administrator and CMMI Director, Dr. Liz Fowler, and she provided some insight into the Innovation Center's models targeting the seriously ill population. We also had several expert panelists and presenters share their perspectives on how to provide patient-centered care, improved outcomes, and measure quality for patients with complex chronic diseases and serious illness and population-based total cost of care. Today, we have a great lineup of experts for 2 listening sessions and a special session with CMS leadership. We've worked hard to include a variety of perspectives throughout this 2-day public meeting, including the viewpoints of previous PTAC proposal submitters who address relevant issues in their proposed models. Later this afternoon, we will have a public comment period and welcome participants either in person or via telephone to share. As a reminder, public comments will be limited to 3 minutes. If you have not registered to give an oral public comment but would like to do so, please email prior to the 2:30 p.m. session today. Again, that's PTAC registration at norc.org. Then the committee will discuss our comments for the report to the Secretary of Health and Human Services that we will issue on addressing the needs of patients with complex chronic conditions or serious illness and population-based total cost of care models. Because we might have some new folks online who weren't able to join yesterday, I'd like the committee members to please introduce themselves today. Share your name and your organization. If you'd like, you can tell us about the experience you may have had with this topic. I'll cue each of you as we go through the introductions. I'll start. I'm Angelo Sinopoli. I'm a pulmonary critical care physician, presently the Executive Vice President for Value-Based Care at Cone Health. I've spent most of my career in large integrated health systems as the Chief Clinical Officer and have built clinically integrated networks and enablement companies to help support their performance. We'll start out by introducing the people who are on Zoom. If we can start with Lauren.
Good morning. I'm Lauren Harden. I'm a nurse and Chief Integration Officer for HC2 Strategies. I spent the better part of the last 20 years directly serving clients with serious and complex illness, starting one of the earliest palliative care programs and children's hospice programs, and then leading a complex care model that scaled to multiple states and was recognized by the National Academy of Medicine. As part of the team that started the National Center for Complex Health and Social Needs, and have spent the last 10 years partnering with communities, large health systems, states, community-based organizations and payers, designing models for complex and underserved populations. And let's go to Jay.
Hi, I'm Jay Feldstein. I'm trained in emergency medicine. I practiced emergency medicine for 10 years and then spent 15 years in the health insurance world, in commercial and government programs, and the last 10 years have been the president and CEO of Philadelphia College of Osteopathic Medicine.
And is Josh on at this point? No? Okay. So next we'll go around the table. If I can start to my left with Jen.
Hi, good morning. My name is Jennifer Weiler, an emergency physician by training. I'm the Chief Quality Officer at UC Health's Metro region and co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions at the point of care. I'm also a tenured professor at the University of Colorado School of Medicine and a former co-developer of an alternative payment model considered by this committee.
Good morning. My name is Walter Lynn. I am the founder and CEO of Generation Clinical Partners. We are a group of medical providers in the greater St. Louis area specializing in the care of the seriously ill and those with complex chronic conditions living in assisted living facilities and nursing homes.
Good morning. Chini Puluru. I'm a family physician by trade. Previously at Walmart, Chief Clinical Executive. Currently, I'm a founder founded a genetics company, as well as served to advise in value-based care transformation. Prior to that, I spent 15 years leading the end-to-end value-based care delivery of DuPage, now Duly Health and Care, which is a large multi-specialty group, one of the largest in the country.
Good morning. I'm Lindsay Botsford. I'm a practicing family physician in Houston, Texas. I also serve as a regional medical director with Amazon One Medical, supporting our practices across the Midwest and Texas. Prior to that, I worked in large health systems and residency education. I also serve as the president-elect of the Texas Academy of Family Physicians.
Morning, I'm Lee Mills. I'm a family physician. I am a principal at Strategic Health Consulting and have spent most of my career in leading and operating value-based care transformation activities, including multiple CMMI models over the last 20 years. Spent the last 4 years as Chief Medical Officer at a commercial and government program health plan, leading those value-based benefit design and care transformation efforts. Thank you.
Good morning. I'm Larry Kaczynski. I am a gastroenterologist by training. I practiced for 35 years in the Chicagoland metropolitan area, but I am now retired from that. I've spent the last 10 years of my life in value-based care, trying to build value-based solutions for specialists, specifically gastroenterologists. I founded a company named Sonar MD, which arose out of a PTAC proposal. We were one of the first PTAC proposals after PTAC was formed back in 2017. And we now have this deployed in the commercial space. I also am a board member of the American Gastroenterological Association, consult for a number of companies, and am the chief medical officer of Jonah Health, an AI-driven microbiome startup.
Thank you all. One of our members, Dr. Jim Walton, is unable to join us for this meeting, but we certainly want to thank him for all his contributions to the meeting preparations. At this point, I'm going to turn things over to Lauren to lead the next listening session. Lauren.
Thank you so much, Angelo. Good morning. At this time, I'm excited to welcome 4 guest experts for our listening session who will present on optimizing the mix of palliative care and end-of-life care in population-based total cost of care models. At this time, I ask our presenters to go ahead and turn on video if you haven't already. After all 4 experts have presented, our committee members will have plenty of time to ask questions. The full biographies of our presenters can be found on the ASPE PTAC website, along with other materials for today's meeting. So I'll briefly introduce our guests. Presenting first, we have Dr. Kurt Merkelz, who is the Senior Vice President and Chief Medical Officer of Compassus. Kurt, please go ahead.
Thank you. Thank you for the introduction, and it's an honor to address this esteemed committee and panel. I wish to quickly just make a comment regarding attribution. My focus is on the highest cost, highest needs users of healthcare, those individuals with polychronic disease states that significantly impact function and account for recurrent hospitalizations. Next slide. This is the opportunity. There is currently a lack of any defined methodology to meet the outcomes most important for this population's success, and in turn accounts for much of the high cost in rehospitalizations that occur. I have only a very short time, so I want to lead with a definition on my thesis for today's presentation. A model of care or methodology is the mechanism for linking theory to practice. It may be the most practical and important tool for a professional. The current model being used to treat the serious illness population is fundamentally flawed when applied to the elderly population with chronic illness, not only for achieving intended outcomes. In many instances and cases, it exacerbates the very challenges faced by these patients. Healthcare providers, including nurses, therapists, physicians, are constrained by current practice. Though well-intentioned, care plans are mostly rendered ineffective because they do not align with the realities of aging and chronic illness management. The persistence of a lack of standardized best practice is a disservice to actually both patients and healthcare professionals. Next slide. My work over the past decade has been to help identify and improve systems of care across a continuum of integrated services, including palliative care, hospice, home health, and infusion services. I have been engaged specifically in improving and standardizing care delivery to fill the gap that currently exists in the post-acute care setting, which is an overemphasis on acute medicine coupled with biomechanical rehabilitation. This rehabilitation model was really born out of young war veterans coming back from injuries from which they needed to recover and for whom physical recovery was mostly possible and necessary. This mindset operates under assumption that restoring physical function or health is consistently possible and desirable. However, for the aging population, particularly those with chronic illnesses, this goal is often unattainable, unsustainable, and unless complete achievement is obtained, it actually leaves them at significant risk. Next slide. My work has been influenced greatly by the Right Care Foundation. The Right Care research initiatives are deeply rooted in the needs, issues, and concerns of specific patient populations and community-based organizations that serve them. Collaboration with communities and patient partners ensures that the research is not only relevant, but also responsive to the challenges faced by our communities and patients. At the heart of my own care delivery model and the Right Care model are substantive outcomes. Outcomes that matter to payer source, providers, and patients that can be realized and in reality must be achieved. Each outcome is strategically aligned with specific actions that are necessary to bring about the desired change to key factors that determine success or failure for each individual patient. Next slide. Currently, palliative care is known to improve the negative aspects to quality of life, mostly by addressing symptoms and stress and serious illness. Additionally, there are known positive outcomes from advanced care planning, timely transition to hospice, and some impact in rehospitalization. However, palliative care as the driver of outcome-focused care, supporting individuals in receiving the necessary and needed care, has the greatest opportunity for impact. Next slide. To illustrate the gaps, consider this recent case of an average serious illness patient. This patient presents with multiple chronic conditions and limited function. The care plan devised for such a patient under the existing care structure focuses primarily on physical rehabilitation, such as performance and components like strength, range of motion, endurance, balance, restoring self-reliance. And nurses are often performing all the required tasks for medical condition management. This patient was found by me at home with no medications, no knowledge of what her medications were, no system to follow the regimen, innumerable safety risks, with an inability to safely have her needs met. This is not a unique or one-off. This is found in almost every home of every patient I evaluate. Next slide. Care for the seriously ill patient needs to focus on care that supports substantive outcomes, not independent goal attainment. Family members, caregivers must be partners in care provision with a focus on supporting the patient in having their needs met, not self-reliance. Palliative care, by using specific care methodologies, focusing on substantive outcomes and validation of training and compliance, like medication reconciliation, medication adherence systems, medication compliance, caregiver assessments and training, and risk mitigation, offers a real solution. A proactive methodology addresses the real needs of patients. Next slide. Many seriously ill patients have been hospitalized precisely because of their inability to manage the very same self-reliance activities we drive after discharge. This analysis from 23,000 treatment plans underscores the need for a shift in how we approach the care of this population. As shown, the care plans for patients admitted to rehab hospitals, skilled nursing facilities, LTACs, and home health most often focus on physical performance and self-reliance activities. These care plans across the board overlook the core needs of these patients, leading to high numbers of safety risks and poor medication adherence. Little to no attention is paid to burden of care and quality of life. The actual number of safety risks present often increases for individual patients with serious illness due to an overfocus on self-reliance, pushing patients to achieve mobility or self-medication provision beyond what they safely should be doing on their own to meet often misaligned goals. Next slide, please. Palliative care, using an outcomes-focused methodology, can raise the bar of high-value care for individuals with serious illness. This approach identifies the essential outcomes that must be achieved and maintained to ensure patient success and reduce healthcare expenditure. It provides a comprehensive framework, including treatment plans and metrics, and it can empower a wide range of stakeholders. Most seriously ill patients are not yet hospice appropriate. So what is needed is to de-emphasize medications and symptom management and align on substantive outcomes that address the needs of seriously ill patients. Successful care often involves family support and proactive management, which our system can often fail to provide adequately. We need to ensure compliance, monitor for changes early, and mitigate risks to keep patients stable. What is lacking, again, is a specific methodology or accounting that can be measured and validated that ensures best practices are employed by every clinician at every encounter. Next slide. Palliative care using outcomes-focused methodology represents the pinnacle of high-value care for individuals with serious illness. A well-defined care model provides a comprehensive framework, including the training, treatment planning, tools, and the metrics to validate goal attainment. A framework of resources such as this empowers and equips a wide range of stakeholders. By realigning the quality equation, this method can dramatically lower the total cost of care, enhancing both patient outcomes and the efficiency of care delivery. Next slide. Specific substantive care delivery models can be developed, are developed, and can be implemented with significant success. Standardized care practices in an individualized way has supported significant improvements in many of the various regulatory quality reporting programs currently in use. And there is still so much more for us to learn and optimize in this area. Next slide, please. And actually, if we can go to the next slide. Compassus, using the care delivery model, achieved CHAP certification as an age-friendly provider in some of their home health agencies. This opportunity extends beyond post-acute care services and directly into our communities. First responders, ERs, community providers, all joining forces around agreed upon outcomes can make the entire community a risk reduction program is actually currently being realized. Right Care has made significant impact in a 3-year pilot with Scottsdale Fire Department, which is now live. Using substantive outcomes training, Senior Solutions recently achieved CHAP certification as an age-friendly provider for private duty care, validating the commitment to high-quality care. The life profile assessment and care planning derived from Right Care research sets senior helpers apart in their ability to execute on keeping seniors out of the hospital by supporting clients by effectively, again, managing their medical conditions, eliminating safety risk, improving quality of life, and supporting family caregivers. This initiative not only elevates their service quality, but also positions senior helpers as a leader in the rapidly evolving field of age-friendly care. Next slide. We need to stop rearranging the chairs and fighting the same focus of care and hoping for a different outcome. Palliative care guiding substantive outcome methodologies can transform care for the seriously ill. By implementing, supporting, and measuring these outcomes, we can achieve better health, reduce costs, and enhance patient and provider satisfaction. I thank you so much for your time this morning.
Thank you so much, Kurt. That was very interesting. We're holding our questions from the committee until after all the presentations are done, but I'm sure there will be lots of additional questions. Next, we're excited to have Dr. Natalie Ernecoff, who is a full policy researcher at RAND. Welcome, Natalie. Please go ahead.
Thank you so much for having me. I'm excited to be here today. You can go to the next slide. I am a health services researcher. I do work in innovative systems, interventions for people living with serious illness, particularly in the hospice space. And today I'll be talking about concurrent care in a hospice context specifically. I'll start out with some background, and like Kurt, I like some historical context, so we'll start there, and then move into some best practices and models of concurrent care, how those models impact outcomes, and what are some of the challenges with care coordination and care delivery in this space. Next slide, please. So the Medicare hospice benefit was signed into policy in 1982. At the time, the policy included a requirement of a 6-month prognosis. It involved relatively inexpensive medications for management of pain and symptoms, primarily in cancer, and the model was developed in cancer care. It also was a home-based model, unlike other hospice models internationally. The home-based care model allowed the policy to remain cost neutral. One important feature of the Medicare hospice benefit is that it does not cover disease-directed therapies that are related to the primary hospice diagnosis. For example, if your primary hospice diagnosis is cancer, the Medicare hospice benefit does not cover chemotherapy or radiation, including if that's for palliative intent, and that's what we'll talk about today. It's important to note that the policy at the time was intended to be inclusive to meet patient needs. Most people who were receiving hospice had cancer, and from the time they exhausted their disease-directed curative treatment options, very few people were living to that 6-month prognostic time horizon. Next slide, please. So 40 years later, the policy remains relatively unchanged. And in today's climate, we see that patients are forced to make, as Kasrat and colleagues called it, the terrible choice. Hospices are unable to afford coverage of many disease-directed therapies, so they often require discontinuation before enrolling, even if those disease-directed therapies can provide comfort-oriented palliative intent. Some examples include palliative dialysis, blood transfusions for people with blood cancers, which can improve dramatic fatigue, and palliative radiation to reduce tumor size marginally if there's a tumor pressing on a nerve causing pain, for example. Patients who could benefit from those disease-directed therapies are often forced to choose between that therapy that can indeed help make them more comfortable in many cases and the improved quality of life and additional support, including psychological support, social support, spiritual care that comes with hospice. But we do see that few patients faced with this choice elect the hospice benefit, and those who do elect the Medicare hospice benefit in this scenario often access the services very near the end of life with less opportunity to see their full benefit. Next slide, please. So what is concurrent care? Concurrent care in this context is continuation of disease-directed therapies with palliative intent upon enrollment in hospice in an effort to support patient goals as they approach the end of life. It's defined by these 3 guiding principles where the treatment is motivated by symptom management rather than curative intent, so treatment plans can change. The potential benefits and burdens of the treatment must be balanced with goals of care and quality of life. And to that end, treatments must be reviewed regularly and treatment care plans modified because the clinical setting and patient physiology is changing pretty quickly and dramatically during this time. So as soon as a treatment ceases to provide palliative intent, it's often discontinued before the very end of life. Next slide, please. So where have we seen concurrent care already? Pediatrics in the United States is one example. So for context, the Affordable Care Act prompted Medicaid policy change in 2010 to allow concurrent care for kids. There is a lot of state level variation in how this is implemented, but in general, evaluations of pediatric concurrent care have demonstrated increased hospice length of stay and fewer live discharges from hospice, allowing patients to continue to receive the benefits of hospice while getting some palliative benefit from their disease-directed therapy. Next slide, please. Another example is from the VA setting. VA administrators found in the early 2000s that hospice enrollment was low. The VA, of course, is not subject to Medicare rules, including the Medicare hospice benefit. And so they decided to test models of concurrent care, starting in cancer. These early evaluations in concurrent care in cancer found that chemotherapy was indeed used after hospice enrollment. It was discontinued before the very end of life, consistent with a comfort-based care plan. And they found fewer ICU admissions, corresponding cost savings there, but no change in survival between people who received concurrent care in hospice and people who received typical hospice services. Next slide, please. The VA also tested this in end-stage kidney disease. And these studies found that median hospice length of stay was indeed longer for people who received concurrent care. You can see here 4 days among hospice enrollees who did not receive concurrent care and 43 days among those who did. Dialysis is an interesting example because discontinuation of the dialysis also leads to a dramatically reduced prognosis, in many cases 3 or 4 days. Next slide, please. So all of this work informed some of what my team and I did in hospice and dialysis in the general population that is subject to the Medicare hospice benefit. So we developed a collaborative program between nonprofit hospice and dialysis companies where they negotiated a contracted rate to cover the cost of dialysis treatments and corresponding transportation to the dialysis clinic from home. We found that about half of concurrent care enrollees actually did not use any dialysis after enrolling in concurrent care. So once they got their feet under them in hospice, saw the benefits that hospice could provide to them and their families, they decided that they did not want any additional dialysis treatments to improve their comfort. We also saw that mean hospice length of stay was about 12 days. This is compared to the national average of about 6 days in people with end-stage kidney disease. And among that subset of people who did receive dialysis upon hospice enrollment, received that concurrent care, length of stay was about 17 days. So these are people who maybe are slightly less acutely near the end of life and were able to really fully see that hospice benefit in greater than 2 weeks of enrollment. This is an illustrative quote from a family caregiver involved in our program. And this family member said after a patient's death, this was a way for us to let his body decide. So this is giving some agency back to patients and their families. Next slide, please. So I want to talk a little bit about the policy landscape in this space, starting with the Medicare Care Choices model. This came up yesterday. MCCM paid a higher per capita fee to hospices, and then fee-for-service Medicare covered the disease-directed concurrent palliative therapies. The hospice was responsible for the administrative burden, including determining if patients were eligible. And the eligible primary diagnoses were limited to cancer, COPD, congestive heart failure, or HIV/AIDS. So MCCM did find higher hospice enrollment and about a week earlier than non-participating hospices. The MCCM program was associated with decreased inpatient care utilization, which was associated with lower costs. And caregivers reported a better experience at the end of life. It's important to note that most enrollees were from large hospices, and many hospices withdrew from the model partway through. Hospices cited operational difficulties, including identifying eligible beneficiaries based on the relatively narrow, what they perceived to be eligibility criteria based on diagnosis. Next slide, please. This is the ongoing value-based insurance design VBID model test, which carves hospice into Medicare Advantage as opposed to the Medicare hospice benefit, which generally kicks people back to fee-for-service upon hospice enrollment. Hospices can provide concurrent care, transitional concurrent care, at a higher per capita fee in the first month of hospice enrollment at the beneficiary level, reimbursement for concurrent care that is related to the terminal condition, and the hospice retains responsibility for treatment plans and care coordination, which is the case at baseline, though concurrent care requires a bit more care coordination than is typical in hospice setting. So the VBID model test is ongoing. Early findings indicate that there was low enrollment into the model and in hospice, and there was no change in hospice utilization between VBID participating in comparison plans in the first year, which is 2021. The VBID model will be sunsetting in 2024, and the evaluation will continue. Next slide, please. What are components of effective concurrent care from the literature? The first is accurate patient identification and well-tread referral pathways, though those referral pathways may be diverse, both from outpatient and inpatient settings upon an acute event that may precipitate hospice eligibility or appropriateness consistent with goals of care. Good communication workflows are essential for interdisciplinary collaboration. So we have pretty tight teams that have pretty robust communication as those care plans continue to shift close to the end of life. Education and engagement is essential both for clinicians and administrators and for patients and families to facilitate goals of care conversations and whether concurrent care is a good choice to meet goals. These conversations in best case scenario start early and continue in an ongoing manner up until the point where someone's goals shift toward comfort and hospice becomes appropriate. Care coordination is also essential and leads to smooth transitions, and the converse is also true. A lack of coordinated care can lead to particularly rough transitions in this new care coordination environment for hospice where they're working with other disease-directed providers. Next slide, please. So the key takeaways here are that concurrent care is feasible and effective to promote timely patient-centered care to retain that autonomy via hospice near the end of life. Feasibility of the model, however, is driven by interdisciplinary care coordination, clinical education, and clear referral pathways and operational support on the ground. Payment models for concurrent care require those operational clinical models. This includes care plans that are modified over time, consistent with both patient goals and the clinical state, interdisciplinary care coordination across multiple clinical teams and providers, and clear but flexible workflows that are met with education and ongoing communication between clinicians, all care delivery settings, patients, and their family caregivers. Next slide, please. Thank you.
Thank you so much, Natalie. Again, very interesting presentation as well. Next, I'd like to welcome Dr. Ira Byock, who is the Emeritus Professor of Medicine and Community and Family Medicine at Dartmouth Geisel School of Medicine. Welcome, Ira. Please go ahead.
Thank you very much. Thanks to the committee for having me. I think my comments will complement those made by Dr. Merkelz and Dr. Ernecoff, and I hope they're helpful this morning. Next slide, please. I want to stay at a high level, at least initially. The culture of mainstream Western medicine sees illness and injury through a problem-based lens. That's very intentional. Next slide. This was concretized, if you will, and reinforced by Dr. Larry Weed's problem-oriented medical record, which is now reflected in billing codes and really focuses physicians, all clinicians, on the problems of illness and injury and the goals of cure, longevity, rehabilitation, and alleviation of symptoms and suffering. Next slide. But from patients' perspective, health and injury and illness are experienced as personal. These are personal experiences. This, by the way, is my father in 1980 meeting my eldest daughter, Leela, the only grandchild he got to meet. Dad was living with pancreatic cancer at the time. Health and illness are personal, next slide, for each individual. But whenever an individual receives a serious diagnosis, his and her family shares in the illness. Now, this conceptual shift, next slide, from problems to patient experience may seem subtle and obvious, but it has remarkable implications for the skill set that we bring, the conceptual framework and that we see the patient experience through, and what actions are brought about by our plans of care. Next slide. When you talk to people who are being wheeled into transplant surgery or facing cancer chemotherapy for the second, third, fourth, or more times, what matters most? The answer will always include the names of other people. This is a constant within the human condition that transcends language and ethnicity, color of skin, and really all the demographics. People also want to make sure that they are not a burden to the people they love, that they retain some semblance of human dignity, that they do not suffer untoward and unresponded to symptoms and sources of distress, and that they feel heard, seen, and understood, hopefully not falling through the cracks of our problem-based medical model-driven system. Next slide. When you shift from caring for illness and injury to caring for whole persons, in addition to alleviating symptoms and suffering and working toward rehabilitating some functional independence, you can look at what exists in opportunities within the personal realm, fostering personal well-being through the end of life, through experiences of illness, dying, caregiving. Now, I'll apply this shift in conceptual framework or expanded framework to doctors' roles in just a few moments. Next slide. During the pandemic, I sketched out for the teams that I was helping to direct within the Providence Health System, a notion of a continuum of human caring that includes, and building on Maslow's hierarchy of needs, includes the human essentials of food and shelter from the elements, the medical problem-based model, which is fine for as far as it goes, of diagnosing and treating people's conditions and making sure that we are aligning what we do with what people want, but also reminding us and visually giving us cues to the other work that we can do within the realm of the personal experience of the patient and family to provide them with real tangible benefits. Next slide. I just want to remind people that back in 2001, the Institute of Medicine, under the direction of Don Berwick's committee, created this 6-component taxonomy of quality, saying that care has to be safe, effective, patient-centered, timely, efficient, and equitable. Next slide. And they defined patient-centeredness as healthcare that establishes a partnership among practitioners, patients, and families when appropriate to ensure that decisions respect patients' wants, needs, and preferences, and that patients have the education and support they need to make decisions and participate in their own care. Decisional support is one of the major opportunities that we have to transition from the medical problem-bound model of medicine to really a human caring whole person approach that honors the opportunity and the potential within our human experience. Next slide. It's easier to write those quality standards than to accomplish them. Why? Because it's hard to have these conversations. And yes, you will be told multiple times that doctors simply do not have the time to have these conversations. That's partly correct, but mostly they avoid these conversations and use the lack of time as an excuse because it's hard to talk about anything having to do with illness and dying. It's awkward within our culture, but for most Western cultures, it feels like failure at times to talk about the eventual death of a person. Death is inevitable, but suffering is not. And these conversations have major impacts on patients' decisions and what they do, what treatments they choose to take or avoid. Conversations can also, as hard as they are, be a source of satisfaction in the clinical experience of professionals. And that skill building has been shown to be effective in making these conversations much easier and make them happen more commonly and with greater effect. Next slide. What to do? Well, we need to make quality standards about these conversations. Make them like completing an allergy list or a medication reconciliation to normalize it. One of the ways to make it easier to introduce these conversations about advanced care planning and goals of care are to simply say, we ask everyone about their preferences, especially who they would want to speak for them if they became unable to speak for themselves. And we ask them to complete an advance directive. Next slide. The other thing that clinicians have to say is, I have an advance directive, and so does every person in my family, which is true for me. I asked my two daughters to develop advance directives when they turned 18. I do so because it's normal, healthy adult behavior. And I have an advance directive, not because I teach this stuff and believe in it, but I do believe in it, but because I have a family. And I know that if I become seriously ill, my wife and daughters will wrestle with decisions about my care. I want to lift a little bit of the burden from their shoulders and give them clear authority to speak for me. Next slide. These days, we talk about shared decision-making as a key component of and process of quality. Shared decision-making has changed a great deal during my lifetime. In the 60s, shared decision-making occurred when the doctor shared his decisions with you. But now, next slide, we realize that shared decision-making, as the IOM mentioned, is a partnership. We doctors come to the clinical encounter, hopefully expert in the diagnosis and treatment of the patient's condition, but patients are already expert in their personal values, their preferences and priorities. Next slide. We need a team of team approaches to really do the best job possible. And palliative care is one of the teams that should be involved when people have serious illness. This is some actual system-wide data from the Providence Health System over the year 2021 to 2022. I use it as an example of why it is important to have these conversations. Now, what I'm showing here is data on people with serious illness by Dartmouth Atlas criteria who were admitted to an acute care hospital. And we looked at, does these patients' code status change during hospitalization? We used code status change as a leading indicator for triple aim goals, if you will, so you didn't have to wait for a cohort to die and look back. And you'll notice that if patients with serious illness become acutely ill and admitted to the hospital, about 19% of them change code status. If they have seen palliative care, that changes to about 35%. If they weren't seen by palliative care, but someone entered a goals of care conversation documentation, the change in code status was 42%. And if palliative care was involved and palliative care probably did that goals of care conversation, it was 63%. Next slide. We worry that patients will recoil from these goals of care conversations, but here's some data from a single hospital within the Providence system that this is Press-Ganey data that shows that people who have goals of care conversations, at least in this hospital, had a higher Press-Ganey score on multiple salient categories of satisfaction. I want you to note that all of these goals of care conversations were conducted by non-palliative care clinicians. We washed the palliative care goals of care conversations from this data before analyzing it. So people didn't recoil, they actually felt better for having it. And notice that these are 10% or more changes or differences in Press-Ganey, which are pretty large in Press-Ganey terms. Next slide. Similarly to advanced care planning and goals of care conversations, we can normalize early concurrent palliative care simply by introducing it to patients as saying our palliative care team is here to provide you and your family with an extra layer of support. This is kind of the team of teams approach that General Stanley McChrystal wrote about in his book. Next slide. When you look at the impact of early palliative care on salient outcomes, again, this is actual data from the Providence system. We saw that when palliative care sees a hospitalized patient within the first Medicare day before the second midnight, in each of these years, they had less days in the hospital than palliative care patients seen initially after that second midnight. Now, this is financially remarkable in terms of bed days saved, but it's also a health outcome because it's harder to fall in the hospital if you've been home for 3 or 4 days, harder to develop delirium, less likely to develop C. diff or other hospital-acquired infections. Next slide. So what are doctors for as we develop new models? Well, here's the list from the problem-oriented approach or problem-bound approach of medicine that we went over. Next slide. But doctors can also be for assisting patients with shared decision-making and treatment decisions, accompanying them through the difficulties of illness and disability, improving their well-being, not just their symptoms, and preserving and fostering people's opportunity to grow individually and together through the end of life. I have 2 more slides. Next slide. I would suggest to the committee that there already is a satisfying model of physician practice that exists in our experience. It's called concierge medicine. Now, I know this has lots of problems and will challenge us as we look at adopting it. But what's important here is that patients love having a concierge physician, and concierge physicians are happy, and that quadruple aim goal of clinician satisfaction and joy at work is best accomplished through this model. Next slide. If I had more time, I would talk about some models that we have worked with or interventions and innovations that we had worked with and some that are coming. Personalizing the electronic health record so that it is less solely problem-based and incorporates SDOH and quality of life indices and shows people's thumbnail photos. I think AI is going to make a huge change in patient reporting outcome measures, or what I like to call them patient-reported information, feeding forward to patients from an interview with an AI avatar rather than the promise surveys, information salient to their health, but also their well-being, and feeding that forward on dashboards so that at the point of contact with the physician, they can be addressed as priorities. Next slide. Thank you very much for the opportunity to present today.
Thank you so much. Another essential presentation. Looking forward to asking more questions. Next, we have Dr. Betty Ferrell, who is Director and Professor in the Division of Nursing Research and Education, Department of Population Sciences at City of Hope. Welcome, Betty. Please go ahead.
Great. Thank you so much. It's an honor to be included in such an important topic today. And I'll be talking about some of the challenges and specifically the workforce to provide all of this wonderful care that we've been talking about this morning. Next. So I think it's really important to acknowledge that nurses are pivotal to the workforce to accomplish anything that we hope to do in the area of serious illness care. So nurses are really the predominant profession in healthcare across all healthcare settings and all patient populations. And nursing care is central to patient and family understanding of their illness, how they manage distressing symptoms, how they transition between healthcare systems, and they are present across all settings at the time of death. And so I think my conclusion that I would present to you at the beginning of this presentation is If you want to create a better healthcare system, that will be impossible to do without centrally involving nurses as the key component of the workforce. Next. Also, I've mentioned that advanced practice nurses are seriously underutilized in serious illness care and have untapped potential to manage patients with serious complex illness. There are many models now of nurse practitioners that are serving in rural communities and underserved populations and really improving serious illness care. Next. We also know this is the Future of Nursing report that was reissued recently, charting the course for 2020 to 2030. And that report, published by the National Academies, concluded that nurses are vital in providing initial assessment of needs of diverse populations, care during disease-focused care, transition to palliative care, initiating hospice, managing urgent needs, supporting family caregivers, providing telehealth, and care at the end of life. Next. So what are the best practices in complex care in serious illness? You know, often I'm asked, well, how do you define palliative care? What's the best definition of palliative care? And there are many definitions, the World Health Organization, the National Consensus Project, but this is the definition that I always share. Quality palliative care is the kind of care that you would want if you or someone you care about is seriously ill. Patient-centered care is complex serious illness, attends to physical, psychological, social, and spiritual needs. So essentially everything Dr. Byock just said about what would truly patient-focused care look like. If we want to deliver that care to patients, then that means we need to train clinicians in how to provide it. But again, if you remember nothing else today, remember the first sentence here. Quality palliative care is the kind of care that you would want if you or someone you care about is seriously ill. Next. So best practices include assessing the person and their family's needs, assessing symptoms and quality of life concerns, a clear understanding of the goals of care, early integration of palliative care, early referral to hospice, and access to support for symptoms and changing needs. And obviously, again, emphasizing changing needs. When you're newly diagnosed with heart failure or pulmonary disease or cancer, needs change over the months or years ahead. And so we need systems that are responsive to those changes. Next. So there's a lot of attention now in the literature and in our professional organizations to what is being called the generalist specialist model. And essentially what this refers to, it's wonderful, wonderful that we have a palliative care service, that we have palliative care specialists. But for example, I work in a hospital with a cancer hospital, 250 inpatients a day, about 700 outpatients a day. That's about, 900 patients a day in my cancer hospital. And we have a palliative care team, which is outstanding. But how many patients today will they really see? You know, maybe 30 patients. And so what about the care of the other 900? So the bottom line is that in all settings of serious illness, absolutely we need our specialists. What's more important is a generalist specialist model. Shouldn't we expect that every clinician in my hospital, a cancer hospital, knows how to provide very excellent palliative care? Shouldn't everyone in my organization be functioning at a high level of symptom management and quality of life attention? So I wanted to just share with you an example. This is a grant that I serve as the PI on. It's funded by the National Cancer Institute through an R25 training grant. And it's called Preparing Oncology Advanced Practice Nurses as Generalists in Palliative Care. And so basically what we've done is to recruit nurses around the country who are advanced practice nurses working in cancer care. So this might be nurses working in a breast clinic or giving chemotherapy or working on a hematology ward. So these are not palliative care nurses, they're oncology advanced practice nurses. And we bring them to this training program and basically give them the palliative care knowledge to infuse into their oncology practice. And so in the first funding through this NCI grant, we trained 430 oncology advanced practice nurses from all over the country. And this is just one little piece of the follow-up data. At 12 months, we follow up to look at documented changes in practice. So not just did they like the course or did they learn from the course, but did it impact their practice? And so we evaluated things like, were these oncology advanced practice nurses more involved with things like family meetings, communicating with the oncologist about the patient goals, and with the patients about their goals of care, referring families for bereavement support and supporting the other clinical staff and end-of-life care. So this paper was published in the Journal of Palliative Medicine. But the important thing is, if we want good patient care, we need to train clinicians to provide it. And there's a very good evidence base now that when we train clinicians, we can impact patient care. Next. Also, I just want to again emphasize that good palliative care applies to every setting of care. And so 2 years ago, I had the privilege of chairing the National Academies of Medicine report on improving care in nursing homes. And the report was issued in 2022. And again, we need to remember that it's not just patients in acute care settings, but patients in home care, in nursing homes, every place that a person with serious illness can be. Next slide. So this is just one slide from that report in the nursing home, is that if we want to improve care in nursing homes, it begins with the workforce, with competitive wages and benefits, staff scheduling, and expertise. For example, having a social worker in each nursing home, empowerment of certified nursing assistants, education and training, and good data collection and research. Next. I think also very critical, as I mentioned, because nursing is the largest part of the workforce across every population and every setting of care, we need good training of clinicians to provide that quality care in serious illness. Next. So over the last 24 years, I've been the principal investigator of a project called ELNEC, the End of Life Nursing Education Consortium. And ELNEC is a partnership where I work, the City of Hope, and the American Association of Colleges of Nursing. And this has been a tremendous partnership because to have the leading nursing education organization in the country, the American Association of Colleges of Nursing, really place a value and reinforce palliative care as an essential part of nursing practice has made all the difference in the world of the changes, the remarkable changes we've seen in recent years. Next. So what do we teach? If we wanted to train nurses, what would we teach them to provide better serious illness care? Well, we use the national guidelines for palliative care. And so these are the domains. This is what the national organizations have all come to agreement about what is quality care in serious illness. It is a general overview of what is palliative care. How do the goals of your care change? It's pain management, it's symptom management. It's the many ethical issues that are confronted on a daily basis by clinicians. It's cultural and spiritual care, good communication, loss, grief, and bereavement care for patients and families. And it is care that is focused on the final hours. So we've taken the national guidelines, what constitutes quality care, and then we've now created curricula for how do we teach this? How do we enhance the skills of the clinician? Next. So the ELNEC project, as I mentioned, is a partnership with the AACN. It started in the year 2000 with funding by the Robert Wood Johnson Foundation. Our first course was held in the year 2001. And this year, January 2024, marked our 300th ELNEC trainer course. So a tremendous opportunity over these years to do a lot of training around the country and around the world. Next. ELNEC is a train the trainer course. So from the beginning, we realized there's over 3 million registered nurses in the country. The only way to really impact care is to create a train the trainer. So when people come to us, they're not only learning the content themselves, but they are going home prepared to teach others. So as of this point in time, we have over 47,000 ELNEC trainers. people who have been trained through our courses to not only improve their own practice, but to train others. These LNEC trainers have returned to their institutions and settings and now trained over 1.5 million clinicians across disciplines presented in every US state and DC. In addition, we also have online training completed through Relias Learning. And one of our most important accomplishments is we've now integrated palliative care for nursing education. So we've created an entire curriculum for undergraduate nursing, an entire curriculum for graduate nursing. As of today, we have, now these numbers are a little dated, but we have over 1,200 undergraduate nursing programs in the country now teaching nurses about palliative care, and over 400 graduate schools, again, preparing our advanced practitioners in how to provide this serious illness care. We're getting close to 100,000 students who have completed all the modules and tested in this content, and those numbers are growing rapidly. And our curriculum has been taught in 114 countries and translated into 12 languages. Next. Also, I think something that's really important is there's common threads. So for example, whether you have heart failure or lung disease or cancer, dyspnea is important. And regardless of if you're in a nursing home or home care, an inpatient hospice or an acute care setting, you have some common needs. But I also want to really emphasize that there is also variation across patient population and setting. And for this reason, we have created several different curriculum. We have a core curriculum, which is our sort of generic, all serious illness. But we also have an entire curriculum for geriatric care, which includes teaching of unlicensed staff, pediatrics, which now also focuses on neonatal and even perinatal care, the critical care setting where issues are very different in serious illness, LNEC for advanced practice nurses, LNEC oncology, and an entire communication curriculum. And then, as I mentioned, we also now have training for undergraduate and graduates, and most of these courses are also available online as well as in-person training. Next. So I think just the bottom line is that the nursing workforce is essential in transforming serious illness care. And if the goal is to improve care of patients, it has to begin with nursing. Thank you.
Thank you so much, Dr. Ferrell. Another essential presentation. Really interesting from all four of you. So next, we're going to open up the discussion to our committee members. So at this time, if PTAC members will flip your name tent up or raise your hand in Zoom. Jay, if you have questions for our guests. And it's difficult for me to see the room. So Angela, if you could help me see the tents that are up, I'd greatly appreciate it.
Do that. Lee?
Sure, thanks. Great presentations. PTAC focuses a lot on measurement and metrics and reducing caregiver burden, that sort of thing. So interested in knowing your advice and what the literature says about what are the approaches to performance measurement in this space that would be most appropriate to help guide the development of total cost of care models involving palliative and hospice care.
I could start kind of putting on my researcher hat with the clinical needs. And, I would just say that we're really fortunate in our field of palliative care because we do have a strong national guidelines that have defined what are those important dimensions. And so we know that symptom management is just a very high priority for patients and families. Are we managing dyspnea? Are we getting the pain under control? Is nausea controlled? And so I would say that, there's been a great deal of work in quality measurement of the key outcomes of palliative care. And so if we look back at each of those domains, pain management, symptom management, are there goals of care conversations? Do we have advanced directives? That there's been a lot of work. And so there are good outcome measures. Groups like the American Academy of Hospice and Palliative Medicine have done a lot of great work of, like the project Measuring What Matters. And so We do have good outcome measures, and we are able to capture the things that are most important to patients and families.
I'll also comment regarding burden. Families, absolutely, symptoms are incredibly important. Families are incredibly burdened by polypharmacy and trying to understand a medication regimen. It's almost, we take for granted so often when we, as clinicians and physicians, prescribe medications and give the prescription to the family and the patient, the failure that takes place after that point. And very often the patient ends up getting labeled as non-compliant. But it's not a matter of non-compliance. They don't understand the importance of how to take medications. There's no one validating that a system is in place. Every home I go into, usually what I find is the bucket of the shoebox of medications, and the patient literally goes pill bottle by pill bottle to decide if this is the pill they're supposed to take right now, or they fill up these medication containers, which is a great next step. But every time I look into it, because nobody's ever validated that they're correct, you'll find, well, Tuesday has 5 medications and Wednesday has 7, and Thursday has 2 of the same medications. This occurs time and time again. And I just did another visit the other day where I walked in the home and the patient's in AFib with rapid ventricular response at 180 beats per minute. It was 11:30. She had a rough night. She hadn't taken her morning medications yet. She hadn't taken her diltiazem yet. Nobody ever told her the importance of taking her medications on her schedule. So a lot of care burden stress comes from a lack of standardization and measures for clinicians to look at what needs to be measured, that patients understand the medications they need to take, that we validate that they're following the treatment regimen, that we validate they're following restrictions and precautions, that they have a system in place to take those medications, that they know what to monitor, and most importantly, they know how to respond when variances occur. When we train families and caregivers in this, stress can go down greatly.
Thank you. And Ira, please go ahead.
I agree with what's just been said. I would also caution the committee away from an overemphasis on outcomes. Most of us have been trained in a Donabidian model of structure, process, outcome, and sometimes we have underemphasized structure and process. The process of goal alignment requires iterative goals of care conversations as people's condition changes, their priorities may change, and that in and of itself is a quality measure. Have these conversations happened in a timely fashion, iteratively as things change? I also want to emphasize the importance of structure. These days we have hospice programs in which there are maybe one physician for 100 to even 300 patients. That's not an adequate structure for a good program. Nurses need, as Dr. Ferrell was mentioning, nurses have to be staffed well enough so that there's not one hospice nurse for 15 to 20 seriously ill patients. That's a prescription for burning out the nurse and for leaving unmet needs on patients and families. So while yes, we need outcome measures, please don't forget the structures and the processes needed to deliver high quality, value-based care.
8 points. Natalie, please go ahead.
Thank you. I'll agree with everything everyone else said and just briefly add to Dr. Byock's presentation that people want to have these goals of care conversations and they want this ongoing communication. They want to know what their prognosis is. And so yesterday we heard about the AHPM's feeling heard and understood measure. And I think those types of measures of what does the care experience look like? Are people having their needs met is essential as well. And also couldn't agree more strongly about Dr. Byock's structure point as well. Is the infrastructure in place? Do we have the resources that we actually need to meet the needs?
Points. Jay, please go ahead.
Yeah, my question is basically for the group, in that we know that, minority populations and issues with health equity get exacerbated a lot of times in end-of-life care. and palliative care. So I was just curious as to each of you, how you're addressing that in your organizations.
Well, I can start. In our training projects, we try to give a great deal of attention to social determinants of health and a lot of attention to culture and diversity in our training. And I think it has to be integrated in everything that we do. And so, it begins with the initial assessment of the patient. What are some of the barriers of, patients that don't trust the healthcare system and have good reason not to trust the healthcare system, or are afraid to communicate their needs. It happens when we get to pain and symptom management in terms of people who live in neighborhoods that don't have access to the medications that they need to relieve their symptoms. It is a part of our failure to do good cultural assessments and to understand important individual beliefs and practices, whether that be spiritual practices or cultural factors that are influencing the experience of illness. And so we have to take every aspect of serious illness care and really, pause to say, this is not one size fits all. But I think it really starts with the things you've heard about today. If we don't start our interaction with the seriously ill person by saying, who are you? What do I need to know about you? Who is your family? Is faith or spirituality important to you? Then if we don't know the patient from the beginning, Harvey Chachanoff is a great psychiatrist and colleague in palliative care. And, he demonstrated with an initial assessment that at the end of that initial encounter, he asked the question, what do I need to know about you to provide the best care for you? And so I think this is not like, here's the tool that will do this. It's more, as Dr. Byock just said, it's the process by which we get to know the patient is the way that we will make sure that we are listening to and responding to diversity.
I think the process by which we go about getting to know the patient, though, does need fundamentally to be communicated and trained. Because when I first started doing this work and looking at substantive outcome care, when I looked at what the nurses and the clinicians provided when they went into the individual patient's home and what they would document, there's on the line of all the forms, there was reason for visit. And what they would document was SNV, which stood for skilled nursing visit. They put the reason they were there in the patient's home, but not what the patient needed. So we had to give specific training and guidance to help identify what matters most to the patient and how to ask and address the greatest concern. So I agree, you need to get to the root of what's important to the patient, but I think our clinicians really need frontline training and really specific actions and tools to drive their performance. Otherwise, I'm left with workforces of thousands of clinicians all doing their level of care. And that type of variability is my biggest enemy towards quality. The best I can do to try to standardize the approach to have meaningful communication, to have meaningful discussions, I think is in the best interest of the patient and the provider.
Natalie or Ira, would you like to comment?
And can I just say, I went the very earliest portion of my brief presentation, I talked about the problem-oriented medical record, and it's a great tool. I mean, it was a really remarkable transformative tool in medical communication and conveying plans of care to other clinicians. But it does focus us on the medical problems, soaping our notes. And I can remember very carefully, very clearly as a young medical student and then young family doc, that it made me feel like the things that were personally important to the patients were fluff, that my job was to deal with the medical problems. And I think we really, if we're going to transform the way care is delivered, including for people with very diverse cultures and priorities in their own lives, we really have to change the way that lens of the medical model and make it more porous to the real priorities of the lived experience of patients and their families.
I can answer the question from a slightly different perspective. Agree with everything we've heard so far. From the research and implementation side, we include members of the communities we work with on our research teams. We involve them in development of the clinical programs structurally. And we try as hard as we can to be mindful of what are the structural barriers people might be coming up against. I do most of my work in hospice and end-stage kidney disease right now. And a big part of this concurrent care work is getting access to those dialysis clinics for people who live in rural areas and are too seriously ill for their families to drive them. So we need ambulance transport. And so how does that look different than it does in urban settings? And we involve members of those communities, both intensively as part of our research processes. We do a lot of qualitative work, a lot of engagement work, and as members of our research team. So they're checking everything that we're doing along the way.
Well, thank you. Walter, please go ahead.
I wanted to thank our panelists for just some really thought-provoking and interesting perspectives. My question actually stems from the kind of evidence that our panelists have presented showing the effectiveness of palliative care in the seriously ill and patients with chronic complex condition population to both improve quality and decrease cost. I think the evidence is very compelling and, it leads me to observe that I think in this population of patients in particular, there's a great underutilization of palliative care services. And I have to think that's probably because of the way palliative care is paid for. I mean, I think all of us here on PTAC probably believe the old saying that care follows finance. And that's why we all serve here, is because we think we can influence care through payment policy. And so my question to the experts on the panel is, what recommendations would you make to the Secretary of Health and Human Services around payment policy in this population of patients to better utilize palliative care?
Can I respond and jump in? Your question is pertinent, and changes in payment policy are necessary. I would simply emphasize, however, that we also need improvements in accounting practices, because palliative care is often seen through the lens of a P&L sheet, a profit and loss sheet. And on a profit and loss sheet, it always loses money, right? It doesn't charge enough to cover the personnel costs particularly. But when you actually bring accounting into the 21st century and look at palliative care, concurrent palliative care's impact on total costs of care, it reliably reduces total costs of care. In every study I've been part of and program development I've been part of, every paper I've read, it reduces total costs of care mostly by reducing the area under the curve of days in the hospital. So if you can meet people's needs without requiring them to come into an acute care facility, you will reduce total costs of care. But even in sophisticated integrated health systems, the CFO and the C-suite often goes to the palliative care team and says, you're just not covering your own costs. That's really bringing 20th century P&L sheet accounting to a 21st century reality. It's inaccurate.
Yeah, actually, Ira, thank you for that. I meant to say, I think palliative care, like you were just saying, is it's very easy to show return on palliative care services under a total cost of care environment. But right now, it's largely compensated under a fee-for-service environment. And so what can we do now to change that, to change the underutilization of palliative care under fee for service, knowing that under total cost of care, it's very easy to show return.
Well, can I just follow up and say you have to link it to a larger cost center, right? And what over my years of work in this realm, including I spent a decade with the Robert Wood Johnson Foundation building concurrent care models. We looked at which entity bears financial risk for this patient's total cost of care, even if it's in a defined period of time, and then link those two so that the risk-bearing cost center sees the benefit of the losses, if you will, or the lack of meeting its expenses that the palliative care cost center will realize.
Other presenters, Dr. Merkelz.
Increasing reimbursement that clinicians receive, increasing reimbursement for home visit, increasing reimbursement for home-based level care, giving clinicians meaningful models, meaningful outcomes that can be supported in the home environment that makes patients successful. Providing reimbursement for this type of activity results in tremendous returns on total cost of care. And it gives the clinician and the patient meaningful outcomes that, when we gave substantive outcome models training to our clinicians, and they go into the home practicing with these outcomes, their mindset has a shift. They said, this is why I became a nurse. This is why I became a therapist. This is why I do what I do. When we move away from outdated performance metrics and misaligned incentives, that leaves clinicians doing minimal documentation and moving on to their next patient. When we give them meaningful outcomes to work from, they really feel empowered in the care that they're providing. And it engages a workforce to enter this workforce, to enter into the home-based care sector, enter into the post-acute care environment where we can really make differences in patients' lives.
From a hospice perspective specifically, I think it's also important to consider the cost of treatment to meet the needs of people receiving hospice now. 40 years after the hospice benefit started, people are living much sicker for much longer, and their needs are much more acute. And reimbursement hasn't changed much. And the population of people who are getting hospice is not only sicker, but much more diverse. It covers many more diagnoses where perhaps marginally more expensive therapies can help meet their needs in a way that's reasonable and time limited and comfort oriented. And so providing the CMMI model tests are currently getting at some of these things. We've looked at these things in MCCM, VBID, some of the disease specific models in kidney disease and cancer. But the population's really changing and the hospice payment model hasn't.
Did you want to add anything, Betty?
I think I would just say, I agree with all of these comments are so important. And I would just say that, going back to concurrent care, I think still remains a key issue. So my research and my primary population is the oncology population. And for the last several years, I've actually focused a lot of my studies on patients on clinical trials. And so it's a perfect, example of we now have third and fourth line, cancer drugs and that are exceedingly expensive. And we have all of these clinical trials. And yet there's so many disincentives of patients, because people with cancer, it's the mindset is what's next? What's next? There's no end point. And so what we have, and we have very strong data. I led a study funded by NCI, almost 500 cancer patients, demonstrating that these are patients on clinical trials that are getting only disease-focused therapy, and they're not getting a well-designed system of patient-focused care. And so 70% were coming into urgent care and ERs with symptoms out of control. They didn't have advanced directives. They were dying in the hospital and with poor patient outcomes, as well as spending a tremendous amount of money. And so we need all the things that you've just mentioned in terms of better reimbursement, better models of care, but we have to move beyond this dichotomy of either you're getting care for your disease or you're getting, palliative care to reduce your suffering and address your quality of life.
Jen, please go ahead.
I too want to give gratitude to the panel for a really thought-provoking conversation. I'm going to go a level deeper with my question, riffing off of Walter's question. And when thinking about payment to incent excellent evidence-based care, which you all have been describing well, we think about two levers, one around maybe direct payment and then another around incentives or penalties. And that's where my question is going to come from. Many Americans die in the hospital setting. One of the quality measures to evaluate inpatient care is the mortality metric, a numerator over denominator, where I think when the hospice benefit is evoked, that takes that person out of an inpatient settings denominator. That's created some interesting national conversation, including in the lay press, around leveraging, that benefit, focused on this mortality metric, maybe creating a perverse incentive. And that metric is one that cascades into many, many Medicare programs in value-based purchasing. It's used in Leapfrog to evaluate programs, hospitals and health systems, and it's used then secondarily in U.S. News and World Report. So my first question for you all is thinking about quality metrics and incentives and disincentives, what your thought is around the mortality metric, because it's so heavily weighted in a number of programs. And is it one that incents us to have these conversations, again, in maybe a perverse way when it is evidence-based? That's one question. And then my other question is going to be around, is there some again, perverse incentive to not have these conversations in the inpatient setting when we have such challenges in the post-acute and home space in getting care, and it pays more to have a person in the inpatient space getting care delivered than transitioning them and not having a place to deliver home-based hospice care. So again, getting deeper into payment, any thoughts on the current structure? And again, back to Walter's question, what are some other opportunities if we're not in a total cost of care space that payment policy might be able to improve our performance and payment for both palliative care and hospice care?
I'll jump in. I don't have that much to say on this. I've never found the mortality scores to be particularly helpful. I do think for certain procedurally oriented disciplines, cardiac surgery, for instance, the O to E, the observed to expected outcomes are more valuable from my perspective. I do think we continue to avoid the kind of the obvious of disincentivizing, or if you will, penalizing clinicians or systems that do not do what there's a strong consensus need to be done, like having a goals of care conversation or an advanced directive on file. We let this go forward and as if, well, that's just the way things are and we're unable to impact it. Dr. Ferrell just mentioned funded studies of cancer care in which a large number of those patients are receiving what I would humbly conclude are substandard health care. because they haven't had those conversations. They don't have a crisis plan. They don't have an advanced directive on chart. We tolerate this, and it perpetuates itself because we keep funding new models that are allowed to go forward with key components of quality and patient care lacking.
It's certainly a very complex area, and my focus and my expertise is really in bedside care and looking at patient needs and patient outcomes. It is a misaligned system. It certainly impacts the ability of us to provide care. I think frequently on how the over-regulatory and misaligned regulatory environment that exists currently within the hospice space. When we know that the Medicare hospice benefit saves the healthcare system billions of dollars. We know even on the very long length of stay patients, they actually have 11% reduction in cost compared to other beneficiaries. So we know even the long length of stay hospice patient is a cost-saving service to our patients. Yet the hospices are penalized and reviewed for long length of stay patients. Well, from the clinician standpoint, we've been caring for these patients in their communities. They've separated from their specialists and their healthcare system, and we've been providing total care for the individual patient. They're now, they've advanced in age, they've advanced in disability, and because of the supportive care that we know is saving the healthcare system money, is causing the patient to have potentially a prolonged life. We have to now discharge them and integrate them back into the system. And that type of fragmented care really doesn't align with the services that are being provided. It's a complex issue. And I think an overzealous regulatory environment that's not aligned with what we know is the outcomes from the Medicare hospice benefit really needs to be squared.
From a patient-centered perspective, there's more and more work that dying in a hospital is not inherently a sign of poor quality end of life for people, nor discordant with their goals, especially if they're part of this group of people who are very acutely, seriously ill near the end of life. And I worry about symptom management, particularly people who are discharging home with hospice and uncontrolled symptoms, especially given the difficulty of accessing inpatient hospices where those symptoms can be managed. And so as we think about incentives in this space, I think that to how we think about getting people into hospice at all costs, maybe isn't the best approach either, that thinking about how we can provide comfort-focused care in hospice settings, cost notwithstanding, is also meaningful and relieve some caregiver burden as well.
You, Betty, did you want to add?
I would just echo, kind of building on Natalie's comment just now. When we really talk about costs of care and who's able to stay at home, it has a lot to do with family caregivers. And so, I do a lot of work with family caregiving over all the years, and we kind of, jokingly sadly say, oh, who's the primary caregiver of the patient? Oh, yeah, it's somebody who's older and sicker than the patient, right? Who's taking care of the end-stage heart failure, cancer, pulmonary disease? It's the family caregiver who looks slightly worse than the patient. And so, the lack of, there are so many social factors, how many people's children live 3 states away. And so, and care is very complex. And so, we just have not built very, patient-centered, models that recognize, and I agree completely, the lack of inpatient options for people at the end of life. And there are people who die poorly at home because they're, one very overwhelmed caregiver has been doing this for 24 hours a day. And so there is I live in Los Angeles. It is so difficult when you have a very difficult social situation to find, an inpatient option for someone to make sure their last days of life are good. And so, you can't understate the family caregiving issues and social issues that are really a part of the quality question here.
Thank you. Larry, please go ahead.
Well, one of the things I love about being on this committee is I get educated. And this session was education for me. And something's stuck with me earlier in the comment where 20th century P&L finances are being used on 21st century issues. And I got thinking, are we trying to retrofit a 20th century care model into a 21st century problem as well? And so my question is, since I heard over and over again that symptom control is critical and that is the major focus. Have any of you worked with any tech-enabled patient engagement symptom management entities in a way of decreasing your own P&L?
I don't think it's symptom management is the key focus. I do think that symptom management is good medical care, basic good medical care. I think the key focus is goal alignment, is decisional support, as the IOM said in the Crossing the Quality Chasm. And there are some tech-enabled solutions coming forward that help with goal alignment and making sure that patients are routinely assessed about their symptoms, their sources of distress, their major concerns, and that the healthcare team can then address those key priorities for patients in the context of their households and families. Symptom management is absolutely requisite, but I think the transformative focus is on goal alignment.
We are definitely seeing creative models of remote symptom monitoring, to your question directly. Whether it's app-based, bring your own device, for example. I know programs like that are led by nurse practitioners, remote monitoring, and can help with triage and various patient education for, guidance. If you have this level of symptom, do this, call your home health nurse. If you have this level of symptom, go to the emergency department. So we are seeing some of that in practice.
And we are leveraging predictive analytics to try to gauge when is the right time to interface and increase our interaction with the patient. So as we're seeing patients that are on a trajectory of higher risk of mortality, we can engage and increase the frequency of our visits and appropriately utilize resources.
I think that's where AI and electronic health records might get very interesting, as prognostic prediction, or systematically identifying people who have repeat acute encounters, and is it time to start maybe being more purposeful about those goals of care conversations or changing care plans.
I agree.
Absolutely.
Betty, did you want to add comment?
No, I just agree with all of these thoughts.
Wonderful. We appreciate all of you joining us today. Each presentation was essential in helping us to understand more about this issue and really look at next phase development in this area. We want to thank you so much for taking the time to be with us today, and you are welcome to join for the rest of the day where we have multiple additional presentations. So at this time, we have a short break until 11 a.m. Eastern. So please join us then. We have a very special presentation with CMS panel discussion planned. So we'll see you back at 11 a.m.
Great. Thanks, everyone.
Thanks very much.
Thank you.
Produced by the U.S. Department of Health and Human Services.